Okay, can you see the screen now? Okay, perfect. So last time we started by some basic concepts about strabismus and how to think about a case of strabismus, how to examine, how to assess a visual acuity, and how to assess the motor examination and sensory examination. Then we went through the classifications of strabismus. So we said that we have two major categories of committant and incommittant strabismus, and they also can be classified according to the strabismus type into esotropia or esodeviation, exodeviation, and vertical deviation. And then we discussed the most of cases of committant strabismus, such as esotropia due to congenital strabismus or accommodative strabismus and others, and also discussed the intermittent exotropia. And now we are going to discuss the incommittant strabismus. So most of the vertical strabismus are belonging to this type. So basically the incommittant strabismus is the paralytic and restrictive strabismus. So let's get started by the first one, which is one of the most important cases of strabismus and that commonly present in the exam, which is the third nerve palsy. As we know from the basic knowledge that the third nerve is supplying the medial rectus and the inferior oblique through its inferior division, and it supplies the superior rectus and the levator papillary superioris through its superior division. So what happens? What happens if there is paralysis of the superior rectus and inferior rectus, inferior oblique, and medial rectus? So basically the eye will have ptosis, this ptosis due to paralysis of levator papillary superioris, and there will be no problem in abduction as the lateral rectus is normal. The lateral rectus is supplied by the abducent nerve, while on looking medially, there will be limitation of adduction due to paralysis of the third nerve or paralysis of the medial rectus. When looking up, there will be limitation of elevation. Why? Because there is paralysis of both superior rectus and inferior oblique. And with this paralysis or this limitation will be most obvious on looking up and in, or elevation in adduction, which is the site of primary or site of maximum action of the inferior oblique. But on looking up and out or on elevation in abduction, there will be slightly normal, more or less normal elevation. Look here, when looking down, there will be still limitation of depression. And in looking down and out, there will be limitation of depression and in abduction because of paralysis of inferior rectus. And when trying to look down and in, like if the patient asked to look to his nose, there will be still limitation. But why? This should be the action of the superior oblique. This is where the superior oblique is maximally acting. Actually, the patient cannot look down and in because of the paralysis of the medial rectus as well. So he cannot bring his eye toward the medial side. So how can we know if the patient has a fourth nerve palsy or not on top of the third nerve palsy? This is we are going to discuss in the fourth nerve palsy, but you just observe the limbal blood vessels. If the patient is asked to look to his nose and if there is intorsion of the limbal blood vessels, then this means that the fourth nerve is intact. If the patient is asked to look to his nose and there is no intorsion of the limbal blood vessels, then there is fourth nerve palsy on top of third nerve palsy, which can be only observed by the slit lamp. So this is just a rapid overview of a third nerve palsy and what's the kind of motility disorders that it causes. So to classify the third nerve palsy, it can be either a complete paralysis of the third nerve, or it is just involvement of specific branches like superior branch or inferior branch. So what is the full-blown picture of complete third nerve palsy? First, we have ptosis. This ptosis is due to paralysis of levator. You may ask me, okay, is it a good thing or bad thing? You can think it is a good thing in a specific way because at least the patient may not complain of diplopia. So this eye or this total eyelid will cover the eye, which cause a prevention of diplopia. As we just mentioned, there will be limitation of elevation, depression, and adduction. And as you can see that the eye looks out, the eye looks laterally. Why? There is lateral rectus, which is intact, bringing the eye outside, and there is depressor action of the superior oblique in abduction. So these muscles that are intact, the lateral rectus and superior oblique will draw the eye down and out. Also, there will be intorsion when the eye looks down and out due to the overaction of superior oblique. There will be a fixed, dilated, irreactive pupil. You remember when we discussed the anisocoria, we said that the third nerve palsy is one of the differential diagnoses of anisocoria as it causes dilating pupil. Why it's causing dilating pupil? Because the third nerve will carry the parasympathetic fiber supplies the constrictor pupillae muscle. And what is the action of the constrictor pupillae muscle? It will cause pupillary constriction. So paralysis of the constrictor pupillae muscle will result in dilated pupil. But does this happen in all cases? The answer is no. There are what's called pupillary involving and pupillary sparing third nerve palsy, and we will come to this in just a minute. Also, since the third nerve supplies the ciliary muscle, it will result in paralysis of accommodation. And as I mentioned to you, there is no diplopia due to ptosis. So if there is incomplete lesion of the ocular nerve, of the oculomotor nerve, there will be internal ophthalmoplegia and external ophthalmoplegia. And by the way, by the word ophthalmoplegia, we mean there is paralysis of ocular muscles. It will be involvement of the intraocular muscles such as sphincter pupillae and ciliary muscles, sparing the extraocular muscle, or it can be external ophthalmoplegia, which will lead to involvement of the extraocular muscles, sparing the sphincter pupillae and ciliary muscle. It can also involve a specific branch. So it can involve the superior branch, leading to paralysis of the levator pulmonary superioris and superior rectus, or it can involve the inferior branch, leading to paralysis of the medial rectus, the inferior oblique, the inferior rectus, and the constrictor pupillae muscle and the ciliary muscle. So it will depend mainly on the lesion. Okay. So let's say that we have a patient who has a third nerve palsy and we want to investigate. How would we investigate? We have two main categories of the third nerve palsy. It can be a medical cause that will lead to the third nerve palsy. In other words, it can be a vasculopathy affecting the blood vessels supplying the third nerve. Or it can be damaged by a surgical cause, like there is a tumor or trauma or aneurysm compressing on the third nerve. So we do the investigations in the form of a blood pressure and blood glucose, blood lipids, and other vasculopathic risk factors in order to assess the risk for vasculopathy affecting the third nerve. And also we can do MRI, MRA, or CT angiography when there is a surgical cause is suspected. So when should we suspect a patient with a surgical cause? First of all, if there is a pupil involving. This is the crucial sign here. Why? Let's see this diagram. This is the third nerve. The commonest cause of paralysis of third nerve, a surgical cause of paralysis of third nerve, will be the aneurysm of posterior communicating artery. The aneurysm of posterior communicating artery is compressing on the superficial part of the third nerve. This superficial part of third nerve is carrying the pupillary fibers. So pupillary fibers run superficially in the third nerve. This makes them the most vulnerable to external compression. So external compression will cause damage to the pupillary fibers, leading to pupillary dilatation. On the other hand, if the patient has diabetes or hypertension, this will lead to ischemia. this ischemia, or there is a problem in the vasa vasorum supplying the nerves, and these blood vessels can be occluded, resulting in ischemia. And which part of the nerve suffers more from the ischemia? It will be the central part. So the central part will suffer more from the ischemia, leading to sparing of the superficially located pupillary fibers. So for most of cases of surgical causes, they may result in pupillary dilatation. Most of cases of pupillary sparing, they are mainly a medical cause. But this is not always the rule. It could be other causes, or it can be the pupillary surgical causes can start by pupillary sparing, then convert to pupillary involving. So you should also look at the full picture. Like if a patient has pupillary involving or partial third nerve palsy involving specific muscles, or if there is aberrant regeneration of the third nerve, or if there is young patient. This is very important. All young patients should be subjected to neuroimaging. So when you ever see a scenario in the exam of a patient with a third nerve palsy and he is young, and they ask you what will be the most likely next step, you should do neuroimaging for the exclusion of posterior communicating artery aneurysm. This is an emergency. Also, if a patient that you deemed him as medical third nerve palsy and it didn't resolve within 3 months, so this is an indication of neuroimaging to exclude a surgical third nerve palsy. Okay, so this is how the patient presents. This is how we investigate the patient. Now, how will we manage this patient? For all cases of of paralytic and restrictive strabismus, you start by conservative management. Why we start by conservative management? Why don't we rush to the surgery? Because the angle of strabismus is usually variable. It tends to improve in some cases. Like if there is a medical cause of third nerve palsy, it can improve if we control the diabetes, give the patient some vitamins. It may spontaneously improve, so we just save the patient from unnecessary surgery. And for other cases, especially for the restrictive strabismus, the angle tends to be variable. So it may show increase or decrease. So we just wait for those patients for 6 months, sometimes up to 3 years. Till then, till the time we decide those patients may need surgery or not, we can do occlusion to prevent diplopia. We offer them prisms, again, to alleviate the diplopia. We can start to buy botulinum toxin injection to the lateral rectus to prevent the permanent contracture and prevention of amblyopia in children. So after this, if no improvement is expected, so we can do the surgery. What is the surgery that we can do for those patients? We are doing the super maximum resection and recession of medial rectus and lateral rectus. And as we agreed the last time, we agreed that the resection will strengthen the muscle and the recession will weaken the muscle. So we do a resection of the medial rectus to more, as it is paralyzed. So we are making it more strong. We do recession to the lateral rectus to make it more weak, trying to align the eye more in the primary position. But do we do this in all cases? Actually, no. We do this if there is residual good medial rectus function. So if there is still medial rectus function, we can do resection. But if it is totally paralyzed, so this surgery will not be useful. So what will be the other surgery that we can do instead? If there is poor medial rectus function, we can do transposition of superior oblique near the medial rectus insertion. This can aid the adduction. Transposition of lateral rectus near the medial rectus insertion. And then the lateral rectus is split into the upper and lower halves and pass under the superior rectus and the inferior rectus to reach the medial rectus. So let me draw this diagram. So let's say this is the eye, and this is the medial rectus, superior rectus, lateral rectus, inferior rectus. Now we have the medial rectus is paralyzed. So we need to try to strengthen the action of the medial rectus or to bring the eye from abduction to more to the primary position. So what we do is we split the lateral rectus into two halves. One half we pass under the inferior rectus and try to insert it near the medial rectus, and the upper half we again we take it, pass it below the superior rectus, and try to insert it near the medial rectus. By this, we are trying to make the eye more in the primary position. So this will be discussed in more details in the surgery, which is a transposition of recti. And we treat the ptosis after correction of diplopia. So basically, or as a general rule, whenever we have a problem in the lid and the problem in the extraocular muscles, we always start by correction of extraocular muscle motility, then correction of the lid problem. This applies for strabismus, for third nerve, applies for Graves' disease, where the patient can have restrictive strabismus and lid retraction. This is the rule, because changing in the position of or manipulations of extraocular muscles can change the relation between the globe and the eyelid. So we need to fix that first, then we deal with the lid. Okay, easy the third nerve. Okay, so let's now move to the next topic, which is the sixth nerve palsy. Sixth nerve palsy is a lot easier. And by the way, the prognosis of surgical correction of third nerve is not that good. As you may expected, that a lot of muscles are involved with this, so it will be difficult to align the eye in the primary position. This may be not the case with the sixth nerve palsy, which involves only one muscle, which is the lateral rectus. So we can see this patient in primary position. When she is looking to the right, she has no problem. When she is looking to the left, you can see there is adduction of the left eye, of adduction of the right eye, but there is no abduction of the left eye. No abduction of the left eye means that there is paralysis of lateral rectus, of the left lateral rectus, where the other ocular movements are normal. So the sixth nerve palsy will be characterized by limitation of abduction. Sometimes those patients may show esotropia and in primary position, and other patients may show orthoptropia in the primary position, and only the sixth nerve palsy is evident on looking to the direction of action of affected muscle. Those patients will have diplopia, which is horizontal diplopia on looking toward the paralyzed side. So the more the look to the side of paralyzed side, the more the horizontal diplopia will be manifest. Also, they will show compensatory head posture. So a compensatory head posture is a head movement toward the head turn to the same side, so it will be like a head pose. The head movement is toward the action of affected muscle. Like if the patient cannot move his eyes to the left, like this patient has left sixth nerve palsy. So the patient assume a head position to the left. He will do face turn to the left in order to look to the areas which he cannot reach by his eyes. Okay, so what will be the investigations? The investigations for the sixth nerve palsy will be the same like the third nerve palsy. However, there is more common reason for each case of ocular cranial nerve palsy. The investigations will be if a patient is old and doesn't have any other neurological deficit. So we are suspecting a an ischemic cause like diabetes or hypertension. So we offer the patient blood pressure and glucose measurement, and we can wait for spontaneous resolution. However, if the patient has associated neurological deficit, or if the lesion is bilateral, or if there is headache or any other ocular cranial nerve palsy, so we may think of another neurological cause. Like, so we do the MRI and neuroimaging. So this is just from the third nerve. We just do MRI. So in order to exclude any cause of increased intracranial tension. And now let me ask you, do you remember when we discussed in papilledema, we said that the patients with papilledema can present with headache and they can present with horizontal diplopia due to sixth nerve palsy. And I told you at the time that this is a false localizing sign that the sixth nerve is stretched over the sharp petrous bone, resulting in its damage in case of increased intracranial pressure. So don't forget that the sixth nerve palsy, you should always exclude increased intracranial tension. The management here will be like the same. For the conservative, we wait for those patients for spontaneous resolution unless there is another surgical cause, which should be managed by the relevant subspecialty, like you refer the patient to neurosurgeon or neurologist. And during the time until there is a resolution, or for the first 6 months, you manage the patient by prisms and occlusion to prevent diplopia, to do botulinum toxin injection to prevent the contraction of the medial rectus and prevent the amblyopia in children. So the surgery, what will be the rule of surgery here? The surgery is done when there is no further recovery is expected, like if there is tumor causing destruction of the sixth nerve, so it will be unlikely that it will improve. So you can do ipsilateral medial rectus recession, like you are weakening the lateral rectus to align the eye in the primary position, or you do lateral rectus resection if there is still residual power in the lateral rectus, or we can do superior and inferior rectus muscle transposition. Regarding the fourth nerve palsy, the fourth nerve palsy is due to paralysis of the superior oblique. Superior oblique is what is the action of superior oblique? It will cause depression in adduction, it will cause intorsion. So this is the eye in the primary position. You can see that the right eye is slightly elevated, or there is a slight hypertropia of the right eye over the left eye. When the patient looks up and right and left, no problem, but look here, where is, yes, it is here. So look here, when the patient is looking to down and left, you can see that the left eye is depressing and abducting normally. It has normal inferior rectus. But the right eye is showing limitation of depression in adduction. This is due to the fourth nerve palsy. So this is the direction of action where we test the fourth nerve palsy. It will be the depression in adduction. So how do we know that? How do we test for fourth nerve palsy? So although that this is a clinical examination, but I'm going to discuss it because it is important for the exams. We can show you a picture of Park three-step test and asks you about the interpretation. So if there is a patient who has hypertropia, we do a Park three-step test. What is a Park three-step test? It is a test that consists of 3 steps. These 3 steps are used to isolate a single vertical muscle palsy. So we have 4 muscles that are responsible for vertical elevation and depression of the eye. We have the superior rectus, the inferior rectus, we have the inferior oblique and superior oblique. Superior rectus will cause the maximum elevation in abduction. Inferior rectus will cause the maximum depression in abduction. The inferior oblique will cause the maximum elevation in adduction, and the superior oblique will cause maximum depression in adduction. So if we have one muscle of those 4 muscles is paralyzed, we can detect it by the Park three-step test. And there is an important thing here is that the Park three-step test is not only for the superior oblique, it is also for other vertical muscles palsy. So how can we do this test? As we just mentioned, it is consisting of 3 parts or 3 steps. The first step is you just to observe the eye in the primary position. So you can see that the right eye is a little bit hypertropic than the left eye. So there is elevation of the right eye. If we have one eye which is hypertropic over the left eye, what could be the cause? It can be due to paralysis of the depressors of the right eye. So who are the depressors of the right eye? It will be the inferior rectus, would cause depression in abduction, and superior oblique, which will cause depression in adduction. Or it could be that the right eye is just normal. It is the left eye is the hypotropic. The left eye, it could be the one that has the abnormality, that it has the lesion. So it could be a problem in the elevators of the left eye. So who are the elevators of the left eye? It will be the inferior oblique and the superior rectus. The inferior oblique will cause elevation in adduction, while the superior rectus will cause elevation in abduction. So we have now 4 suspected muscles that are causing this right over left picture. How can we isolate a single muscle? Then here we come to the second step. The second step, we ask the patient to look to the right and to the left and check when the elevation is increasing and when it is decreasing. As you can see, when the patient looks to the right, we can see that the hypertrophy almost disappeared. This means that the muscles which act upon looking to the right are normal, which are the inferior rectus and the inferior oblique. So both inferior rectus and the inferior oblique are normal. And the hypertrophy is increasing while the patient is looking to the left. This means that it could be either a problem in the depressor of the right eye or the elevator of the left eye. It could be a superior oblique palsy of the right eye or a superior rectus palsy of the left eye. So we have here again 2 muscles which are incriminated. How can we isolate which muscle of them? We do the 3-step test or the 3rd step. So I guess that you expected that. What is the 3rd step of the Park 3-step test? We are doing head tilt. So by doing head tilt, what will we do? We again check for the improvement or worsening of the hypertrophy. When the patient had head tilt to the left, you can see that there is improvement of the hypertrophy. Why? If the patient is doing head tilt, there is what's called the vestibulo-ocular reflex that should adjust the eye position. So when the patient is moving his head to the left or doing a left head tilt, there should be extorsion of the right eye and intorsion of the left eye. So if the intorsion muscles of the right eye are intact and the extorsion muscles of the left eye are intact, there will be disappearance of the hypertrophy. And here we are testing the left eye is we are testing the superior rectus. We have the superior oblique and superior rectus. The superior rectus is causing intorsion, so it is normal. So there will be normal intorsion of the left eye, so the hypertrophy will decrease. And we are testing in this position the extorsion of the right eye, and the extortors, which are the inferior rectus and the inferior oblique, the extortors are here are normal. So again, no problem. But if the patient is tilting his head to the right, what happens? There will be worsening. There is a worsening of the hypertrophy. So if the patient is tilting his head to the right, it should be that the should be intorsion of the right eye and extorsion of the left eye in order to adjust the position again by vestibulo-ocular reflex. But what we can see here is that there is hypertrophy, increasing the hypertrophy. This means that the muscle which acts as intorsion in the right eye at this position is paralyzed. What is this muscle? It will be the superior oblique. So superior oblique here is the paralyzed muscle, or it is the one which is responsible for the hypertrophy. To summarize, I will repeat it again, don't worry. If you don't need to remember all this, you just remember this mnemonic, Woog and Boot. Woog and Boot is a mnemonic to remember the 4th nerve palsy, which is worse on opposite gaze and better on opposite tilt. When we have a 4th nerve palsy, like right 4th nerve palsy, it will be worse on opposite gaze. It will be worse on looking to the left, as you can see here. The patient, when looking to the left, it was worse. The hypertrophy increased. It is worse on opposite gaze. and it is better on opposite tilt. When the patient is making head tilt to the left, it is better. It is better on opposite tilt. Okay, so this is the first step. It is a primary position. Second step is the right and looking to the right and left, or right and left gaze. Third step is the right and left head tilt. Let's repeat it again on an actual patient. So this is a patient who has right hypertropia. This right hypertropia means that there is a problem either in the right inferior rectus or right superior oblique, or left inferior oblique or left superior rectus, either the depressors of the right eye or the elevators of the left eye. So we ask the patient to look to the left and right to isolate the muscles. When the patient looks to the right, it looks normal. The hypertropia disappeared. This means that there is intact inferior rectus muscle and intact inferior oblique muscle. When the patient looks to the left, there will be increasing in the hypertropia. So this could be a problem in the depressor of the right eye, which is the superior oblique, or the elevator of the left eye, which is the superior rectus. So we do the third step, or the head tilt. When the patient do head tilt to the left, there should be corrective movement of both eyes. So the right eye should extort and the left eye should intort. And since that the intortor of we are differentiating now between the superior rectus and superior oblique, and since that the intortor of the left eye is intact, which is the superior rectus, it will be no problem. There will be improvement of the hypertropia. But what happens if the patient is tilting his head to the right? Well, there should be intorsion of the right eye and extorsion of the left eye. And since that the intortor of the right eye is damaged, or the superior oblique is paralyzed, there will be inability to intort the eye, leading to elevation of the right eye, causing increasing in the hypertropia. So to remember them, again, we have the mnemonic WOOG and the BOOT. WOOG is worse on opposite gaze, and BOOT, it is better on opposite tilt. Okay, clear now? Okay, perfect. So by knowing these facts, or by knowing these details, now let's talk about the fourth nerve palsy and what are the difference and what are the clinical features of the fourth nerve palsy. In the fourth nerve palsy, we should classify it according whether it is unilateral or bilateral. So unilateral fourth nerve palsy and bilateral fourth nerve palsy. What is the kind of limitation and how to test? For unilateral fourth nerve palsy, there is limitation. There is depression on abduction on one side. So there will be ipsilateral hypertropia in primary position. Because it's only one side, so there will be hypertropia of one eye. But for bilateral cases, there will be depression on abduction on both sides. So there will be no difference between both eyes. There will be no hypertropia between both eyes. The limitation will be limitation of abduction in the down gaze, which is unilateral, leading to what's called V pattern, or V pattern esotropia. Do you hear my voice? Is my voice clear? Okay. So the limitation is in abduction in the down gaze, which is unilateral, causing what's called significant V pattern. What is the V pattern? So V pattern, it is just what's called alphabetical pattern. There will be extorsion of the eyes on elevation and esotropia on depression. So the eyes will assume a V position. I will just bring you some photos for it later on. So for cases of bilateral fourth nerve palsy, there will be abduction in down gaze, or it is bilateral, causing V pattern esotropia. So for those patients who have bilateral fourth nerve palsy, there will be overaction or secondary overaction of the inferior oblique muscle. And this inferior oblique muscle is abductor. So when the patient looks up, the inferior oblique will cause abduction, cause excessive abduction, leading to more abduction in the up gaze, leading to that the eye will assume a V-shaped position. Let me just draw it. So when the patient is looking down, his eyes will be like that. When the patient looks up, his eyes will be like that. Why? Because of the secondary overaction of the inferior oblique. If inferior oblique is an elevator of the eye, so when the patient looks up, it is elevator and abductor, so it will cause abduction of the eye, leading to increasing the abduction. So the patient's eye looks like a V pattern. When he looks down, it will cause a more esotropia. When he looks up, it will be more exotropic. So this is the pattern for fourth nerve palsy. It will cause V pattern, but the reverse occurs with superior oblique overaction, or if there is a superior oblique overaction, it will cause A pattern. So A pattern, this is the A pattern. So in the A pattern, the eyes looks more esotropic in up gaze and more exotropic in down gaze. This is like the A pattern. This is caused by superior oblique overaction. The superior oblique overaction is a depressor. So if it is overacting, it will cause more abduction in depression, leading to more exotropia on depression, leading to the pattern of A pattern. Okay. So this is just to describe what is the meaning by V pattern and A pattern. There are other patterns that we are going to discuss later on, but this is just for now. So this V pattern is more prominent or more obvious when the patient has bilateral fourth nerve palsy rather than unilateral fourth nerve palsy. In both occasions, there will be limitation of intorsion because the superior oblique is intortor muscle, so there will be limitation of intorsion. And this will be an objective test that can be done in order to detect this intorsion. So there will be excyclotorsion of the fundus. Like if you can see this is the optic disc, and this is the fovea, and this is the macula. So when you see the fundus, you will see that there will be excyclotorsion of the right eye and excyclotorsion of the left eye. So you will see that the eye is a little bit rotated. So the optic disc is a little bit higher and the fovea is a little bit lower than usual, which means that there is excyclotorsion of the fundus. And this can be checked by the indirect ophthalmoscope. So this is an objective method to check the presence of excyclotorsion of the fundus. It is just a tilt of the fundus. Or we can do this by subjective method, which is the Maddox rod. Maddox rod show also extortion. So how can we do this? Remember when we checked the Maddox rod? Let me show you the Maddox rod that we mentioned last time. Here is the Maddox rod. So the Maddox rod, the patient should see a vertical line by the red eye and red vertical line by the green eye. Those two lines, they should be parallel to each other. This means that there is no cyclotorsion of both eyes. If one eye is a little bit tilted, so this means that there is cyclotorsion. And we measure the angle between the difference in the scale of the trial frame. Like there will be one line at 90 degrees and the other line will be 90 degrees as well. So if there is cyclotorsion, it will be, if it is unilateral, it will be less than 10 degrees. So the line may be present at 90 or 95. But if it is bilateral fourth nerve palsy, the difference in cyclotorsion will be more than 10 degrees. Okay, so this is a subjective method So as the patient will report that the line is tilted, and we ask him to rotate the knob until the line looks vertical again. So that's why it is subjective. Okay, continue. Let's continue the other test for the fourth nerve palsy. So by Maddox rod, there will be extrusion in one side. By Maddox rod, in case of fourth nerve palsy, there will be extorsion marked, which is more than 10 degrees. Okay. Head tilt, if we did do head tilt to the patient, we can see that the head tilt increase on the same side. Remember, boot better on opposite tilt. This means that it will be worse on the same tilt. So if the patient has like this left fourth nerve palsy and you tilt the patient's head to the left, this will cause worsening of the hypertropia. If the patient has bilateral fourth nerve palsy, it will be right hypertropia on head tilt to the right and left hypertropia on head tilt to the left. So let's assume that this patient has bilateral fourth nerve palsy. If you tilt the head to the left, there will be increasing the hypertropia of the left eye. If you tilt the head to the right, there will be increasing the hypertropia of the right eye. Another way of presenting the abnormal head posture, it is the chin depression or the compensatory head posture. There will be the chin depression or elevation, face turn, or head tilt. So these are the different measures or presentations of the abnormal head posture. For those patients, they are unable to depress the eye. So they will depress the chin. They will present with chin depression. They are unable to tilt, to do intorsion by their eyes. So they will do intorsion by their head, like they will turn their head to opposite direction. If they have left hypertropia like that, they will be associated with contralateral head tilt. They will do head tilt to the right because this position will decrease the diplopia. So it will be causing face turn to the right and head tilt to the right as well. So this will be because of the unilateral fourth nerve palsy. But if the patient has bilateral fourth nerve palsy, they will only do chin depression. Only chin depression, not the full picture. So just assume that those patients who had fourth nerve palsy, they took a slab. They took a slab on their face. Like assume that this patient has a slab over his right face or left face. What this will cause? This will cause chin depression, will cause contralateral face turn, contralateral head tilt. This is like a way to remember what will be the abnormal head posture of the fourth nerve palsy. Assume that the patient has a slab on his face. So he will, if he has a slab on this left face, it will cause left fourth nerve palsy. And he will be having a chin depression, having face turn to the right and head tilt to the right. So this is how difference between the unilateral superior oblique palsy and bilateral superior oblique palsy. So this patient has right hypertropia due to right superior oblique palsy. You can see that this hypertropia disappear on the it become worse on opposite gaze. So if it is patient is looking to the left, becoming worse, this hypertropia increase and it disappears on the right gaze. This is the second part of the Park three-step test. Okay, look here, when the patient is looking to the right, no abnormality. When the patient is looking to the left, there is limitation of depression in adduction of the right eye. Okay. So for this, on contrary, for this patient, when this patient has bilateral fourth nerve palsy. So you can see that you cannot appreciate the hypertropia because you don't see the difference between both eyes. When the patient is looking to the right, there is hypertropia of the left eye. When the patient is looking to the left, there is hypertropia of the right eye. So Park three steps, the second step is positive in both directions. When the patient is asked to look to the right, there is limitation of depression in adduction of the left eye. When the patient is asked to look to the left, there is limitation of depression in adduction of the right eye. So this means that the patient has bilateral fourth nerve palsy. Okay, this is what will be some of the features that will differentiate between the unilateral and the bilateral fourth nerve palsy. So for those patients, when we investigate, usually we need to ask about if the patient is congenital or acquired, if it is present since childhood or not, and if it is medical, it can be due to hypertension or diabetes as well. But also don't forget this trauma. Trauma is a common cause of fourth nerve palsy. So trauma can affect the crossing of the fourth nerve, which present at the dorsum of the midbrain. This dorsum can be and due to that, the fourth nerve is a long and slender nerve, so it will be more liable to trauma. So how can we treat the fourth nerve? Again, we conserve for 6 to 3 months Hello, can you hear my voice? Okay, so I'm speaking about the surgical correction. So if the patient, if the cause is permanent and there is no improvement is expected, we offer the patient muscle surgery. Again, the muscle surgery can be a little bit challenging because of the a little bit of complex action of superior oblique. So the patient has hypertrophy. So we want this hypertrophy is due to elevation over action of the inferior oblique. So how can we improve this hypertrophy? We do weakening of the direct antagonist, weakening of the ipsilateral inferior oblique by inferior oblique myectomy. This is one of the weakening procedures. Or we can strengthen the weak muscle. Like if there is a still residual action of the superior oblique, we can do what's called ipsilateral superior oblique tucking. Tucking is a procedure in order to strengthen the muscle. Weakening the yoke muscle or the contralateral inferior rectus, like if the patient has hypertrophy of the left eye, we can weaken the inferior rectus of the right eye in order to make both of them a little bit hypertropic. So we do contralateral inferior rectus recession. Okay, so these are the different procedures that can be done for the patients with inferior oblique palsy or with the fourth nerve palsy. So to summarize, the important causes of each one of these ocular cranial nerves palsy, Dr. Marwa is asking about prisms. Prisms are unlikely to improve the diplopia in those patients because of that torsional diplopia. Those patients have paralysis of intorsion. So they will see the images not only vertically or horizontally displaced, but they also tilted. And this prism is unlikely to correct this tilting. Okay, back to the causes of the third and fourth and sixth nerve. So the third nerve is all of these lesions or all of these ocular cranial nerve palsy can be caused by vasculopathic risk factors such as diabetes or hypertension, or it can be due to surgical causes such as tumor or any compression of this nerve. But each cranial nerve has a specific rule or a specific cause. Like the third nerve, it can be caused by aneurysm, specifically the posterior communicating artery aneurysm. The fourth nerve can be specifically caused by congenital causes or trauma. And the sixth nerve specifically can be caused by increasing in the intracranial pressure. A nice way also to remember this is was an old song in the 17th. It was called "Nobody Knows You When You Are Down and Out." So remember, down and out is the effect of third nerve palsy on the eye. So nobody wants you when you are third nerve palsy. And also that the fourth nerve is the muscle which is responsible for depression and in adduction. So it is the muscle responsible for descending on down the stairs and reading a book. So if the patient has a problem, or if the scenario is telling you that there is a problem during reading, or there is a problem during ascending or descending downstairs, always consider a fourth nerve palsy. Dr. Marwa, Prismus, it has no rule. It has a limited rule. As I told you, it is limited rule. So it can be tried, but it will be, we don't expect that much from it. Okay, so this is the ocular cranial nerve palsy. Any questions in the ocular cranial nerve palsy?